Thank you, Brian, for those kind words. One of the great things about being the last welcoming speaker is that a lot of what I wanted to share with you has already been shared. And so I won't belabor the points, but I do want to make a few comments. And I do want to congratulate, can I put this down without turning it off? See, I finished my residency 30 years ago when the MMWR came out with the first case reports of what we would eventually call AIDS. So we didn't have a lot of the technology that we have today. So I do want to recognize and congratulate the important collaboration with HRSA, not just the HIV/AIDS Bureau, but certainly the Bureau of Primary Health Care, and the critical non-governmental partners, the Health HIV and the National Association of Community Health Centers, as well as many others, probably too numerous to name, in coming together with this vision about how to extend the capacity of community health centers to address HIV/AIDS in their communities. And simply stated, from the federal government's perspective, that's what our interest is. We're not asking you to take on issues that are not already in your communities. We are asking you to take on issues that are in your communities and that affect many men, women, and children who live in your communities, and many of whom might actually be clients at your community health centers. So I was asked to just make a very few comments on what is the role of community health centers in achieving the National HIV/AIDS strategy, and simply put, the role is critical. Several of the introductory speakers this morning have noted that as a group of committed professionals and community advocates, I think we're all beginning to realize that we are reaching the limits of how we can address HIV/AIDS solely through categorical approaches. And although categorical programs like the Ryan White program have been nothing short of life-saving, and they will continue to exist, though in the new environment of the Affordable Care Act, they will morph in different ways. Although they have been critically important, I think more and more everyone is coming to recognize that we must make HIV care part of routine primary care, because we simply cannot address all of the issues solely through categorical programs. And there have been a number of important indicators signaling that change. I mean, that's a very different change from the early days of the epidemic. And Brian noted that on June 5th, we did observe the 30th anniversary of the first case report in Morbidity and Mortality Weekly Report, published by CDC, of 5 homosexual men from Los Angeles who had pneumocystis pneumonia. And of course, the clinicians in the audience know that it was peculiar because pneumocystis pneumonia is typically an opportunistic infection that we see in people who are older, who have been under therapy for malignancy or other treatment where their immune system is shot. And no one could understand why these previously healthy gay men had come down with this mysterious illness. And 30 years later, of course, we know why. But I think when we look at that, initially it was highly specialized. A lot of healthcare providers thought, oh, this is some kind of quirky thing that the CDC is reporting, and it's not going to be anything that will affect my practice. But obviously, in 2011, we now know that the CDC, for the past 5 years, for instance, has been saying that HIV testing should not be risk-based, it should be routine. Now, that doesn't mean you don't test someone who comes forward and says, I've had unsafe sex or I've been injecting drugs. But what it does mean is you need not solicit a risk history from your client in order to test him or her for HIV. And the reason for that was the persistent documentation of a substantial number of men and women who are infected with HIV, often in systems of care and undiagnosed. So certainly by the time their immune systems are shot, they'll eventually be diagnosed, but by then they've suffered permanent damage to their immune system. They've likely transmitted the infection unknowingly to partners. And so for those reasons and many others, CDC said we recommend that back in 2006, we recommend that in all healthcare facilities that HIV testing be routine. So that was an important signal. As I said to you, there are a number of important signals about why healthcare providers, including community health centers, need to be recognized as critical partners in this effort. The ongoing observation in the United States that HIV/AIDS disease disproportionately affects racial and ethnic minorities, especially African Americans and Hispanic Latinos. Again, the populations that you serve. And in some parts of the country, in certain communities, we see very high rates. In other racial and ethnic groups, like Asian Pacific Islanders and like American Indians and Native Americans. So again, these are the clients you're serving. Another really important reason why the field is moving toward embracing a more and a broader primary care perspective, and in this regard, I'm highly influenced by my previous job. I spent 4 years at the Department of Veterans Affairs, running their office at headquarters that dealt with program and policy related to HIV as well as chronic hepatitis. And the average veteran with HIV in care in the VA system is over 55 years of age. And most of them are men, though some of them are women. And often they have a number of other substantial comorbidities. So they have cardiovascular disease, they have hypertension, they have metabolic disorder. So there's a reason why the field can no longer just say, well, HIV, that's a job for an infectious disease specialist. More and more, everyone is recognizing that we have to develop the capacity to treat where it's appropriate. And again, the point I'm making is that you have people in your community and probably some people in your systems of care who are maybe undiagnosed with HIV. You may have people in your systems of care who've been diagnosed but are having challenges being retained in care. And so it's just critically important that we strengthen and broaden these relationships. And again, Brian made reference to the National HIV/AIDS Strategy, which was released last July, the first ever comprehensive national U.S. strategy. I mean, there certainly had been strategies from individual agencies and individual groups, but this is a government-wide strategy. And if you haven't looked at it, by all means, take a look at it in your folder. You can also look at it online at AIDS.gov, and you will see not only what the Department of Health and Human Services is committing to in order to achieve the goals of the strategy, but also what the other 5 key federal departments have indicated that they will undertake as part of their operational plan. So when the President released the National HIV/AIDS Strategy, he identified 6 lead federal departments who needed to step up and implement the strategy. Certainly at the top of the list was HHS. And I don't say that because that's where I work. I say that because the Secretary of HHS, Secretary Sebelius, and the Assistant Secretary for Health, Dr. Howard Koh, were tasked with coordinating not just what was happening inside of our department, but across these other 5 departments as well. And they are Department of Labor, Department of Justice, Department of Veterans Affairs, HUD, and the Social Security Administration. So by all means, take a look at that. But when you look at the HHS operational plan, you will see a lot of references. You know, you'd expect to see a lot of references to the HRSA's HIV/AIDS Bureau and the Ryan White program, and you do, but you're also going to see multiple references to the Bureau of Primary Health Care, how we can work better with community health centers, how we can bring in and strengthen other kinds of partnerships. And I'm just going to close very briefly by telling you this is a learning community, and I think it's great. I don't think there's anything, well, I think learning is up there, way up there on the things that most human beings like to do. And I think most human beings feel a real sense of accomplishment when they can learn and master something. So I regret that I can't stay here with you all day today, because there's certainly a lot that I have to learn. That's the first reason I regret it. The second reason I regret it is it's hotter than hell out there. It's about 6 blocks to the metro station. But you know, having said that, I think you all, as Brian and Kathy and others have noted, have a tremendously exciting agenda in front of you. But just very quickly, one of the things the federal government is trying to learn, and let me tell you, it's a tough lesson, I don't want to minimize it, is how we can work together better at a federal level. Here's the metaphor. I mean, you all as providers, you all understand the importance of various providers and disciplines coming together to serve patients and clients. I mean, that is the essence of primary care. Bringing these together through various systems of care, whether it's one-stop shopping, whether it's the 3 coordinated C's spinning together, whether it's case management. But we all understand that for certain patients and clients, multiple disciplines and multiple providers, whether, you know, not just medical, but nursing, pharmaceutical, social work, psychosocial services, have to kind of come together in a way that makes sense to the person, so that the patient isn't overwhelmed with, you know, where do I go to get all this care? We kind of have a similar issue in the federal government, if I can use that metaphor. We have a number of extremely high-functioning and important programs, but they're in vertical silos. So we've got prevention over here at CDC. We've got the categorical HIV/AIDS Ryan White program in HRSA's HIV/AIDS Bureau. And then we have yet another extremely important bureau, Bureau of Primary Health Care, that deals with community health centers. We have our substance abuse and mental health services in yet another federal agency, SAMHSA. And then all of the research that we're supposed to be doing that's informed by not just the basic scientists, but is informed by communities, that's in yet another center, the National Institutes of Health. So part of what we're trying to do is, and people have been asking for this for decades, it's not a new ask, but I think it gives you an idea of how complicated it is. We're trying to see at a local level, can we do a better job pulling this together? I mean, the intention is not to blow up the programs and make one big mega federal entity that deals with everything. Again, think of the analogy of how we coordinate care. But what we are trying to do at the provider level is we're trying to see what can we do to make a stronger integration between prevention, treatment, and care for HIV/AIDS. So simply stated, when you look at our operational plan and you read about the 12 Cities project, that's what we're trying to do. The 12 Cities project is being built on top of an existing CDC funding announcement that went out last summer called ECHIP, which stands for Enhanced Community Prevention Planning and Program Response. And CDC provided additional funding to 12 metropolitan statistical areas in the United States that collectively accounted for 44% of all persons living with AIDS. And I will tell you furthermore, I don't have the statistics at hand, If you look at those 12 cities, I believe it's certainly over half. I think it's maybe 56%. 56% of those persons living with AIDS in those 12 cities are African American. So they're also, they don't represent the entire national epidemic, but they certainly represent a big chunk of it. So CDC put this announcement out and it's chugging along, and then at HHS when we saw it, we thought, isn't this a tremendous opportunity to bring HRSA, HIV/AIDS Bureau, HRSA, Bureau of Primary Health Care, SAMHSA, NIH, HUD, and Indian Health Service, and others together and figure out how we can help our partners at the local level cut across these vertical programs so that they can have not just improved planning, but the most important issue is improved response. I mean, the reason we plan is to make outcomes better, not to have more meetings and write books, despite what you might think about the federal government. We're trying to enhance the planning so that at the delivery level, the services are better. So again, that's part of what we are attempting to achieve. It is definitely still a work in progress. One of the major issues we're grappling with right now, which will absolutely require the attention at the secretarial level, is how can we get the agencies to try to agree to a common set of program measures. And not only that, but how can we get them to put those program measures on a diet? Because the providers, whether they're from the health department or a non-governmental organization, are just saying, you know, we don't have the, you know, we understand why you need to monitor, we understand accountability, but we can't measure 150 things. We just don't have the capacity. So that's what we're dealing with right now. And so we have a lot of things to learn as well. But to end on a positive note, I again want to circle back and say that this learning laboratory, having all of you here and the vision that HRSA had, HRSA, Bureau of Primary Health Care, and the key non-governmental partners have displayed in working with all of you to understand what your issues are and to help you develop capacity to better serve communities where you're located. It's just tremendous, and I couldn't be prouder of all of you or my federal colleagues. So I will say to you, stay cool, number one, keep well hydrated, number two, and learn a lot while you're here. Thank you.